Diabetes mellitus is a disease characterized by elevated blood glucose level. Type 1 diabetes, juvenile diabetes, results from the body's failure to produce insulin. It occurs before the age of 20. It represents 10 to 20% of diabetic patients, prone to ketosis and characterized by very low serum C-peptide levels. It is treated by exogenous insulin. Most cases of insulin-dependent diabetes mellitus result from the destruction of the insulin-producing beta cells by the immune system. One of the most common autoantibodies found is an antibody against glutamic acid decarboxylase enzyme. Histocompatibility antigens are present. Islet cell antibodies are present. It is polygenic. Viruses and toxins might be implicated. Type 2 diabetes, non-insulin dependent, also called type 2 diabetes or maturity onset diabetes, usually occurs after the age of 40. Results from insulin resistance, defect in insulin secretion, or inappropriate glucose production by the liver. Treated by anti-diabetic agents. It represents 80 to 90% of diabetic patients, mostly obese. Resistant to ketosis, endogenous insulin present but insufficient. Normal or increased C-peptide levels. Diet control and exercise are required. The most common cause of insulin resistance is the downregulation or defect of insulin receptors. There is no histocompatibility antigen association. Islet cell antibodies are absent. Strong genetic association, obesity and physical inactivity play a role. Insulin deficiency leads to increased hepatic gluconeogenesis and decreased glucose utilization, leading to increased hepatic glycogenolysis, provoking hyperglycemia and excessive loss of water, leading to dehydration. Insulin deficiency leads to increased hepatic ketogenesis, decreased ketone utilization, leading to increased lipolysis, provoking hyperketonemia and ketoacidosis. Sulfonylurea derivatives. They stimulate insulin secretion, reduce hepatic uptake of secreted insulin, and reduce the glucagon levels. The sulfonylurea is essential for activity. The second generation of sulfonylurea derivatives are bulkier than the first generation and more potent. They are more lipophilic and of higher duration of action. Glanides stimulate insulin secretion. They are of rapid onset and short duration of action, taken immediately before or with meals. These agents provide increased insulin secretion in the postprandial period. Biguanides. Metformin inhibits gluconeogenesis, increase glucose utilization by the cells. Its effect does not depend on the presence of functioning beta cells, nor on the secretion of insulin. It lowers blood glucose levels in hyperglycemic patients, but has no effect on normal glucose blood levels. Thiazolidinediones, glitazones, are insulin sensitizers, agonists of the nuclear receptor termed peroxisome proliferators activated receptor gamma that decreases insulin resistance. There are 3 parts responsible for the activity: the lipophilic tail, phenoxyalkyl linker, and the acidic head group, acidic hydrogen, essential for the activity. Alpha-glucosidase inhibitors, similar structure to sugars, but with simple differences. Nitrogen instead of glycosidic oxygen. Cyclohexene instead of pyrene ring. False substrate of alpha-glucosidase enzyme. They prevent the hydrolysis of carbohydrates to monosaccharides, preventing their absorption. They act on alpha sugars. Dipeptidyl peptidase 4 inhibitors. Incretins like glucagon-like peptide 1 and glucose inhibitory polypeptide are a group of gut peptides that stimulate the secretion of insulin from beta cells and suppress glucagon release, decreasing blood glucose level. DPP-4 is an enzyme responsible for the degradation of GLP-1 and GIP. Inhibition of the DPP-4 enzyme increase incretins and decrease the blood glucose. DPP-4 inhibitors may have a risk of progressing cancers, as DPP-4 is believed to be a tumor suppressor of some cancers and may increase heart attack risks. Sodium glucose cotransporter protein subtype 2 inhibitors. All are C-glucoside derivatives. SGLT2 is a glucose transporter responsible for glucose reabsorption in the kidney, leading to excretion of glucose together with isoosmotic amount of water. Blocking this transporter causes about 50 to 80 grams of blood glucose per day to be eliminated through the urine, corresponding to 200 to 300 kilocalories. Additional water is eliminated, resulting in lowering of blood pressure. The body responds to reducing energy by burning fat reserves.